Thank you very much, Meg and Dean, for terrific presentations. Thank you. So we now have quite a bit of time for discussion, and I would like to start with a couple of questions for our speakers. And first, I would ask Meg, since you're already talking on policy, we know that health literacy can address health disparities in access to care and health outcomes. How does this integration address these issues?
I'm hardly the expert on this, I think, but I think when we're talking to policymakers, that's the case that we need to make. I think we really have spent a lot of time talking about the prevalence of disease, and I think it's really difficult for, and I can speak to sort of congressional offices, we can talk about state legislatures, which is slightly different. In a congressional office, it's very hard to sort of understand the impact of disease by just talking about prevalence. And I think when we talk about disparities, we tend to talk about disparities in access to care or disparities in who has the disease burden, and have not really talked about how oral health has created larger disparities in economic mobility primarily, but also within communities. And what are the driving forces behind that? You know, is it how we teach? Is it how we pay for care? I think there's different ways that we can address the issue to point out oral health as part of a larger system instead of just focusing on the disease burden. Because I think when it comes to, everybody's walking in with their disease, right, to an office to say there's disparities in all of these areas, whether it's diabetes or heart disease or all of those. I think what we need to show is that this is actually a contributor to your disparities instead of the disparities within the disease.
Can I just add to that, which is, I think you're absolutely right about talking about the consequences of oral health disease and just riffing off what you were saying in your slides, and to demonstrate to the policymaker that if you work this way on oral health, you're also benefiting the diabetes, the heart disease, the stroke, the pregnancy. It's a win-win. So you're getting a lot of constituent buy-in and advocacy organizations, et cetera. By working on this thing, it just happens to help oral health, you know, but you could be agnostic to the disease. And I think that's of value because they don't, you know, they're looking for the win-wins.
We were just having a discussion yesterday with a state advocate about a policy strategy they were trying to go forward on oral health. And so they were very focused in on what they thought they could accomplish. And of course, we're like, we think you could accomplish more. You know, we think you should push the envelope. But I said, I think when you're looking at the allies, the dentists are clearly an ally on this specific issue. I said, the issue is there's more, you have more allies. You have early childhood. You have, you know, the brain science of 0 to 3 on board with you. You know, have all of these. And I think, and trying to convince some oral health advocates that you need to start rallying the troops around sort of a pregnancy and 0 to 3 issue. You need to start rallying the troops that aren't just the people that you know. Yeah, and that really showing state legislators that, you know, the 0 to 3 brain science people are on board with dental benefits in a different way for young kids is a more powerful tool than walking in just with the dental society and with an oral health advocate. And I think getting people to start thinking about who else is impacted by the policy change you're trying to seek is going to be more fruitful moving forward. I think for some people, I did a presentation last week also to try to point out the consequences of not doing this. And a recent Medicaid waiver that went through for adults in Kentucky specifically, their Medicaid waiver had work requirements and different things that sort of went along with that to what we would consider restrict access to all sorts of health services. In keeping ourselves separate, that waiver is a very indicative of if you meet your work requirements and you have these extra health savings accounts, so to speak, the things that you could use that money on if you meet all the requirements are vision services, dental services, out of over-the-counter medications, and a gym membership. So at this point in time, oral health services are equal to a gym membership in the eyes of many policymakers. And while I think gym memberships are great, I'm not sure that it falls on the same category as trying to control diabetes in the same way from a clinical standpoint as sort of a gym membership. I think that was alarming to people that hadn't looked at some of that, but keeping ourselves siloed outside of the health system makes us look much more like a gym membership than it does
Particularly if
them.
having good oral health helps you get the job.
Yes.
And meet the requirements.
No, exactly. Very cyclical of how you get that job.
So I hope everybody's getting ready to ask our two speakers questions. I have one question for Dean, and this really has to do with one of the 21 recommendations that our primary authors of the major report had to say. And in your opinion, how do we encourage the conduct of studies of the impact of health literacy on integration of preventive oral health services into primary care and preventive health services into dentistry?
So this is not a public health literacy question. This is more about clinical care delivery, right?
It's overall both. It would be both.
Okay. Well, let me start with the public health literacy, and then I can go to the clinical. I think the two issues that, or two or three that come to my mind with respect to public health literacy. The first is what we've been alluding to, which is to really get a handle on the potential cost benefit, which this could be done with modeling studies. For example, we got funded to do an evaluation of the impact of the soda taxes in Berkeley, Oakland, and San Francisco, and comparing it to LA, which is not taxed, and to extrapolate reductions in consumption to a range of diabetes outcomes, not including oral health. So including cost effectiveness. So if we or others could be modeling, whether it's a natural experiment in Kentucky or a natural experiment in California, to determine to both estimate and determine the cost benefit of public health interventions that impact common shared risk factors, that would really help make the case to policymakers as to why integration of any health intervention would be beneficial. The second public health issue, I think, is, you said it a number of times, which is we keep saying it's a chronic disease, but people aren't really understanding it. And so let's talk about the consequences, and I think that's true. I do think there's some fundamental research we need to do on how do we communicate to various stakeholders, whether they are the general public or policymakers, on oral health in an integrated fashion. Okay, cavities, okay, gum disease, which one causes tooth loss? Which one is really the problem? Which one causes which? And not to go into too much detail, but to really understand the kind of words that would resonate with different audiences, I think is a fundamental scientific question that we need to answer. In the clinical domain, I think we need to do a lot more. Well, fluoride varnish should be something that people should be coming into the office and asking for. I had the situation the other day when I was dealing with a patient with heart disease and diabetes. Whenever at the end of the visit, she said, "Aren't you going to put me on a statin?" And I was like, first of all, why are you not on a statin? And how amazing that she asked me that. I think to really activate the general public around fluoride varnish as a basic human right, I think would be really, really important.
And drinking community.
And then I think that this is the other thing I was going to say that brings to both the public health and the clinical together is the issue of fluoridated water. And I know that in the 70s, 80s, there was research around fluoridation campaigns, but this is 2018, and there's a whole counter culture movement related to fluoride not being cool, and it's part of gluten-free, fluoride-free. Tom's best-selling toothpaste is fluoride-free, prominently displayed on their toothpaste. So how do we, in clinical settings and in public health campaigns, talk about fluoride in a different way? Because it's still seen as the nanny state. And we should be telling our patients which of the waters have fluoride in them. We should be encouraging them to drink tap water, and we need to figure out how do we communicate to low-income populations who have real fear around drinking tap water, often for really good reasons, and kind of thread that needle. I'm sure there's many, many more things in oral health literacy that can be done around integration. I can say that it is not enough to tell me, because half of my patients have diabetes, that I need to look in the teeth and the mouths of my patients, because really I just don't have a place to send them. And so we have that access to care problem that is a huge barrier. So I think we need to focus on the preventive oral health literacy messages until we figure out the access problem.
Very good. Thank you very much. We'll open this up now to our members, and I see one down here.
Hi, my name is Michael McKee. Thank you for the very useful presentations. I mean, it was great to just get an oversight on some of the drivers on how oral health can impact health. So as a family medicine physician, obviously with my primary care work, I'm still struggling and also concerned about the ongoing expectation. I know we talk about this concept of integration, but the clinical delivery keeps going back to primary care physicians. We are right now overwhelmed. We're overtasked. And I think I'm also struggling with this sort of business model. The dentistry is a rather influent profession, and primary care providers make a lot less than dentists do. So the concept, even like with varnish, our clinic is very avid proponents for it, and we are doing it. It's not easy to incorporate into our daily practice. We are reimbursed roughly about $8 to $10 for doing this varnish, which I think is on top of everything that we do. I mean, we're averaging 5 or 6 clinical problems, and then we have this varnish expectation. And we were approached by the dental school as trying to address a lot of these gaps. But I challenge dentists to really own up and really address these gaps that are really oral health that they need to really tackle. And so I'm just throwing this caution and just constantly bombarding primary care physicians, expecting more, and trying to address all these health disparities. We need to make sure that the clinical care delivery also needs to be on the burden of dentistry. We need to get them at the places where there's gaps. So I just wanted to kind of change, because this is a really important topic, but how we can do this effectively would be really critical. But we need to also be realistic about the expectations and where the burdens are, and make sure that is shared and fairly distributed.
Thank you.
Go ahead. Yeah, I think it's a question too.
So
To one of
I
us.
want to honor sort of what happens in a pediatrician's office and the amount of work that goes on. Even when I just witnessed my own children going to the pediatrician. I have 2 thoughts. One, I think the work that we do is really trying to figure out how to adequately reimburse primary care settings so that it does create time and space for that to happen, because of the natural ability of a pediatrician to do that, probably more so than a dentist, when it's to the point of the integration of you're already asking about how much juice is being drank, how many, all the things that are the common risk factors. And so how do we build in the system that actually allows for that time and the reimbursement to do that? So that is one bucket that I sort of want to honor what's already happening, and that the current system is inadequate for a primary care setting. The second issue I want to address is we focus on where risk assessment could take place for young children, on really identifying kids that are at the highest risk level for caries, and how do we get them into a management protocol. And I would posit that doesn't take a clinical person to do most of that. Is that where are families? Where can we reach families at the very youngest age and the earliest stages, so that can be communicated and coordinated amongst physicians and dentists, but that it doesn't take a clinical setting to do much of the oral health risk assessment. There are people that run in, that are seeing families every single day that have a better sense of what their actual risk is and would be more trusted individuals to actually get information from families. And so part of when we look at...
Can they intervene, though? He's asking about the intervention part. Can they intervene?
I think you would, to be able to create a team approach with other providers in that family, though, to say a management protocol for a family is this family really should go to a dentist, right? And how do the clinicians sort of communicate that? But kids aren't in physician's office every day either. They're in childcare settings, they're in WIC clinics, they're in many different places that could serve as the entry point into whatever a management protocol would be, not to leave it only to the two clinicians that see families on a not so regular basis.
Go ahead.
And I just want to make one comment. First, as a primary care doc, completely validate what you're saying. Second, we know, and this is not just true for oral health care, it's true for mental health care, it's true even for problem number 4 in your physical health problem, that the model, the individual doc model, is just doesn't work. And so we have to move to team-based care. We have to. It's painful to get there, but once you're there, it's glorious. We have to have payment models and accountable care organizations that allow us to do that. We have to find other health professionals who have the skills needed, because we're not talking about, drilling and root canals in primary care. We're talking about things like in behavioral health integration, which was described in the commission report. We now have a behaviorist in my clinic, and it's amazing. Now I have expectations around behavioral health that I didn't have before from the system, but that's okay as long as we have the behaviorist. So it is not a solo practice operation by any means. And if we think we can integrate that way, you're absolutely right. It's going to be just dead in the water.
Mm-hmm. Yes. First, Susan, yes.
Hi, my question is more around helping to build the evidence base, or maybe the evidence. And one of the things I was curious about, how much issues around oral health have been integrated into the All of Us initiative, which is, doing broad data collection on all types of health issues, because it seems, and also recruiting from federally qualified health centers and that kind of thing. And so I was just curious to what extent research questions have been presented to the All of Us initiative, or oral assessments are being included in that data collection. I was just...
I don't really know the answer to that. How about, do you?
Does anybody know details of the All of Us? We have somebody in the back. Go ahead.
Thank you for that question. I actually had it as a star beyond just discussing it in terms of where it is in terms of All of Us, but also in health disparities and the relationship there, and I'd like a conversation about that later. But actually, as we were putting this together, fortunately, so I'm the director of NIDCR, and fortunately, NIDCR was included in the early stages of trying to get survey questions. But as you can imagine, as they started narrowing things down in the first move forward, they were not included. But I think I'm now allowed to say that in this current wave, there will be oral health questions. Good. So great question, but it's a bigger picture.
And is it just a survey, or are there also biological samples and exams that are part of the All of Us?
So blood is still the biological versus saliva, but with young children and those that have difficulty, they will do salivary samples as well. And of course, then when you're screening and you have this question, then you can do the variance analysis and have that.
But there's no like anthropometry, blood pressure and height and weight.
Yeah, there are a whole bunch of measures.
But they don't look in the
that are
mouth
considered,
for that.
But not mouth.
Okay.
Okay.
Coming.
Yeah.
Take a photo, right?
We're
Yeah.
adamant on that.
Thank you very much. Terry, please.
Alice, excellent panel. I want to ask you, I love the public health varnish deal, and I want to hear more about that. In working with early childhood education with the most at-risk kids, trying to provide wraparound, we have no oral health going on. I mean, we could, who can varnish the teeth? How do you get that done? That, you are giving people something rather than asking them to take away something. And you're not, access to care, you're eliminating that. So would you just discuss this public health varnish?
Well, I wish we had a public health varnish. That's a damn good idea. But I mean, can you, Meg, talk about the details of this? I mean, Jane and Susan, I think, are the most appropriate to answer the details.
I mean, for application, California is the best example. I mean, almost anybody in California can apply varnish. I mean, there's not a credentialing sort of issue. I mean, there are companies that mail varnish out to adults to do themselves. I mean, varnish is not a difficult thing to do without some clear training. So, I mean, I know California has one of the most expansive laws that allows sort of basically anyone to do
The
it, right?
deal
Gail?
is the kid is in school.
Yeah, totally.
Yeah, so actually in California, we are working on
Yeah, you're on.
in California now. In California, we're working on different initiatives, taking the varnish to the children. Exactly. So doing it in WIC sites, doing it early Head Start sites. The skill itself is simple. I used to joke it's as easy as putting on nail polish, which I realize less than half of the population does. So at the time, I taught my 5-year-old to do it. So now when I train other providers, I say, if you have the skills of a 5-year-old, you too can do this application, which can be a major benefit to our children. And so trying to find places where we can do it in the community is definitely part of the movement we're working towards.
Can you mention any risks
So
of
there,
overdoing it or?
so we are about to publish a study saying even up to 9 times a year will not be a problem. It's currently covered, for instance, in California, twice a year in the medical environment, three times a year in the medical, twice a year in dental, and then so we can have additional initiatives to add on top of that without any detriment, without any sign of fluorosis, without any other problems. There is a hypothetical risk of the allergy to colophony, which is part of the resin. I can say our practice has done it, and we're a medical practice. We've done it over 10,000 times and never had a problem.
Who does it at Head Start?
So there are different models for it. Some are using dental hygienists in the community to do the application. Some are doing local training of the local teachers. And so then the question is about reimbursement. Right now, it's being done through pilot projects, but looking to integrate it into FQHC billing, so it would be.
Thank you very much. We have to move on and get these other questions on. And next is Jennifer, and then Gail.
I'm Jennifer Dillahay with the Arkansas Department of Health. I'm really sorry that Brian Hill couldn't be here because I was thinking of some of the work that we've been doing in Arkansas. The State Board of Dental Examiners has determined that it's within the scope of practice for dentists to prescribe HPV vaccination.
I was going to talk about that.
And that is a primary prevention for oral cancer. And so the issue is then how do we integrate the prevention for this oral cancer with dentists and medical, the immunization programs, the providers? So they would write a prescription and the pharmacist would fill it and provide the immunization and then access the registry. All of that can be done from a policy legal point of view now. It's how do we in a state or any community develop the bridges so that it can be done in a seamless way. And of course, health literacy is a really important part of that because the dentists now need to be able to communicate with their patients in a health literate way about HPV vaccination, just like any other like healthcare provider would be able to communicate about vaccination.
Right, correct.
Can I comment?
Yeah, quickly.
Just a quick comment. So I just 2 weeks ago diagnosed a young man with cancer of the base of the tongue from HPV. Primary care providers don't know about this problem. It is is it the leading cause of head and neck cancer now? The number 2 after smoking?
Yeah.
Certainly the general public doesn't know about it. I mean, maybe they know about Michael Douglas's cancer, and that's an opportunity. But we need to improve health literacy simply around this collateral benefit. And then I think the workflow issues are going to be unique to probably each practice, not just the state. But I don't have a quick answer for that. But if we're focusing on health literacy, to make the link that the same virus that causes cervical cancer is causing head and neck cancer, oral cancers, would be a very big accomplishment.
Yeah, I agree. Thank you very much. So now we have Gail and then Jane.
Thank you. Gail Matthew from California Dental Association. I just want to make a quick comment to sort of bring together what Dr. Schillinger has been talking about and Meg Booth. In California, the Dental Association worked for years advocating with policymakers to provide more resources for oral health. We consistently heard, where's the money? Show us the money. Like, where's that supposed to come from? And so putting together a coalition of a multifactorial coalition of American, the Medical Association and the American Heart, and many stakeholders came together for policy advocacy to pass a tobacco tax in 2016 that is now funding activities in the State Office of Oral Health, building an oral health public infrastructure that never existed in California. And those of you in California are shaking your head because you're hearing some of the result of that. So we will watch for the down evaluations, because we are managing to build that public health infrastructure that we all know must be to be successful.
So
with our
just to
goals.
reiterate, a tobacco tax was put on the ballot, a high tobacco tax, mind you, on top of a high tobacco tax, which passed. And the revenue from that tax, in part, is being used to fund oral health infrastructure.
Yes, a dedicated portion is going to our Office of Oral Health and the infrastructure.
exactly.
And that money's much of it is being pushed out to local health departments to do on the ground work. So more to come there. It was really everyone working together, that interprofessional,
it's a great model.
It was
cross-cultural.
great. Yeah. Thank you very much. Yes, Jane from the
Thank you very
ADA.
much. So I'm Jane Grover. I'm a public health dentist with the American Dental Association, and we have policy on the HPV, bidirectional referral and patient education. We also have and have enthusiastically supported application of topical fluoride varnish in a variety of settings, and have worked with states to make sure that folks had access to fluoride varnish and to work with our physician colleagues. Prior to coming to the American Dental Association, I was at a community health center for 12 years. And if there was ever a living laboratory and a network of medical dental integration, that was possible, because the dental clinics struggle with finding patients, and the medical community, being right across the hall frequently, can work more closely together. That's why we developed a community dental health coordinator program, which is spreading across the country. So we applaud the opportunity to work with physician colleagues and promote oral health and prevention of disease.
Thank you very much, Jane. I have one question. Yes, please.
On the wrong side of the room. I was really interested, Megan, in your conversation about the surveys that you were doing and sort of the focus group interactions. And I was thinking about, we all have experience with dental experience, oral health experience from our very early childhood, and most of us don't like it, and it sort of hurts a little bit, and it makes me think of other things that often hurt, like pap smears and mammograms, and there's a whole set of medical things we're supposed to do for prevention that we don't like to do. And I wondered if there was any conversation about that among the folks that you talked to, about how that impacts even the conversations that they have with policymakers, and how that sort of changes what people want to talk about and what they're willing to talk about, and sort of their interest in this as a problem. Because I'm sort of struck by, we're really good at doing things that are easy and required in our face, or things that are urgent based on, we see blood and we go deal with that. But this idea that we need to do this prevention thing, that's
it
not
hurts.
fun, right?
It builds character, though.
It totally builds character, but I just wonder, in your experiences in the groups, did people talk about?
I'm going to ask Amy in the back, as people that sat in the room for most of them, but if there was discussion of it, I don't know for sure. It didn't sort of come out in the reports of sort of the report out. I mean, I will say part of the discussion with a lot of pediatric dentists and sort of different feelings about how early kids should be in a dental chair. I do think, like, my kid's experience with a dentist is very different,
Yeah.
Than my own. I mean, I think this is sort of the evolving practice of, it's not painful for little kids, and so my kids love going to the dentist, right? I mean, I think it's an amazing, awesome place to hang out,
Watch videos that they can't
totally watch
otherwise.
videos. There's fish. There's a cool dentist there. Like, awesome things happen, and so I think some of that is us too. I mean, and an argument for getting kids in early and sort of having them used to having people in their mouth and sort of probing in their mouth. But I don't know specifically sort of if the fear issues didn't seem to come up sort of in there.
In those focus groups, it certainly didn't rise to the top as a key issue around it, but more around the other issues of putting those guidelines on.
Yeah.
Okay. Other questions? Going once? Oh, sorry, Nicole.
It wasn't quite a question, and we can talk about it later. I'll just make it brief. But I really, really appreciate the fact that you brought up, Dean, basic health communication principles in terms of oral health messaging, the words that we're using, how they're being interpreted by the different and various target audiences, the integration of how we can incorporate that with other professions. And then the biggest thing, too, I think that may have been assumed is who the messenger is and what that means and what the impact is for the public.
Right.
Certainly lots of research opportunity there, and the fact that you laid it out in your presentation so nicely, I really, really appreciate that.
Thank you.
Yes, research funding is what we need. Yeah, no question. Good research. Oh, please join me in thanking our speakers.
Let me add to that thanks, Dr. Horowitz and Dean and Meg. Let me add to that thanks. Very well done panel. Dean, I must say that we need to have your presence a little bit more in the community to better understand the whole issue of public health literacy. I think it's something that's quite important. And I love that upside down T from San Francisco. It really makes the point quite well. So thanks very much. Well, we will now break for lunch. We have about 1 hour. Some logistics related to this. It's always easy, but let's just understand the logistics here. The speakers, the moderators, and the roundtable members will have lunch in room 101, same place that breakfast was. The audience members are welcome to eat at the refectory, which is on the 3rd floor, and probably a little easier than going out where it's a little chilly. But there are a number of restaurants if you would like to utilize the restaurants nearby. So we'll convene for the afternoon at about 1:15. We anticipate as much fun and knowledge in the afternoon as there was this morning, so enjoy lunch.